Leave it. No worries.
Okay, sir.
Yeah. Okay. Tripti, మీకు అవుతుందా? You're able to share the screen?
Sir, I'm unable to see the screen sharing.
Bashir, just see that. I think every one of you having a slide. See, why don't you share, Achyut?
Yes, sir. Yes, sir. Achyut, you can. So, good afternoon, sir. Kuchalavu.
Good afternoon, sir.
Mogul Pettandi, sir. Kuchalavu garu Mogul Pettandi.
Yeah, everybody's logged in?
Yes, sir. Yes, sir. Almost
Okay.
16 people.
Okay.
Good afternoon,
Good evening.
sir.
Good afternoon, all of you. Today we are starting the first time in Visakhapatnam. We have a thought of starting this academic curriculum, especially due to the IDSM people who are recent in a future also will get a lot of students also comes, and all the institutions are taking up this teaching program. I hope not only a everyday clinical discussion at the bedside, we should also need some exam oriented. The people should be aware of how the examiners will ask during their case presentation, and that is the most important. Ultimately, you have a clinical knowledge, but you should not able to say during your presentation is the most important. What you have, know it, but practically you may do it, but theoretically or so representation is also most important during your exams. That's why I discussed with Mohan Maharaj and other senior people in Visakhapatnam. Why don't start like other centers, especially Hyderabad and everywhere, where I have a lot of classes are going on. We should start to our students to be benefited. What we have, lot of teachers, student faculty are there, experienced intensives are available in Visakhapatnam. They can share, they can advise, they can give their opinion about the teaching program. I think this is the first class we are starting today. I hope in the future we'll conduct more classes and it will benefit to all the students. Just few my remarks. I will request the moderators to start the class, and also Dr. Mohan Maharaju say a few words about how to go ahead for this future, this program. Thank you, sir.
Thank you, sir. Nothing else, sir. Let the program go well, and all of you are going to participate and make it to the heights. Please go ahead, Mondo and
Yeah. Thank you, sir. It's been my pleasure to conduct this kind of academic sessions. And thank you, ISCCM and Mohan Maharaj and Dr. Kuchalavu, sir, for initiating to conduct a Vizag intensive care case studies. As you know, last 13 years, ISCCM Vizag chapter has been conducting various kind of academic programs. For case discussion, this is the first kind of academic session. And to analyze this program, we have decided to, we all together and ISCCM, Mohan Maharaj sir and Kuchalavu sir and Achyut and everyone, to conduct this program every Wednesday between 3 to 4 p.m. from each hospital as per schedule. We'll release the schedule also very soon. I request each hospital HODs to actually participate to make success this program, especially from all the HODs from the CARE, Pinnacle, and KIMS Icon, Apollo, and Medicover. Coming to today's program, the presenter is Dr. Tripti, which is going to present a case study today. And today's moderator will be Dr. Achyut, who is working as a HOD and a Director of Anesthesia and Critical Care Services, Apollo, Arilova. As you, Achyut, no need of introduction, he did MD Anesthesia and FRCA, London, and he has a huge experience in anesthesia and in critical care, especially in neurocritical care and liver transplantation. With these words, I request Dr. Achyut to take over. Before that, I request all the participants to mute their mics, sincere request, and also type their questions in the chat box. Over to Achyut. Tripti.
Yes, sir.
Yeah. Good afternoon.
You
Mohan, I think.
Achyut,
Tripti-
1 minute, Achyut.
Yeah.
Can you enable? Then only the slides moves. In this top, it is given a enable editing. And go to the slides. Yeah, go ahead, Achyut.
Yeah. Tripti, are you able to share it now, or are you struggling to share?
Sir, I'm still struggling to share the PPT. Can you please do it on my behalf so I can?
The only problem is the changing will be difficult. Slide change will be difficult if I do that. Basha, who is that? Basha is doing that, sir. Mohan, sir.
Bashir.
No problem, sir. Your Bashir is there and Mohan. We can do it ourselves, sir. Mohan can do it. No
And
problem.
I have slides with me. I can share
No
it,
problem.
but
Yeah, you can do it, sir.
Dr. Tripti can't change the slides if I do
No problem.
that.
She will tell the next slide.
Okay. Shall I share the screen now?
Yeah, go ahead, sir. Go ahead, sir.
Good afternoon, everybody. Good afternoon, Kuchel Babu, sir. Good afternoon, Mohan, sir. David, sir. Mohan Rao, sir. My teachers, Rani, madam, and all my colleagues. Today, I'm going to present a case on subarachnoid hemorrhage. I would first like to thank Dr. Mohan Maharaj, sir, for giving me this opportunity to present the case. I have taken this case in Medicover hospitals, and I'm going to present a case on subarachnoid hemorrhage. So the case presentation is as follows. Next slide, please.
1 minute.
Actually, maximize the screen.
Just none, sir.
This iPhone, who is that? They cannot take it out.
Yeah, I'll just.
That hand you can raise your hand should be.
So the history of
Are you able to see the screen now?
Yes, sir.
Yeah.
Okay,
That,
go ahead, please.
that hand raise is there. That you cannot remove.
Sir,
So
which one, sir?
only she has to remove.
Somebody's hand is raised. That
No,
iPhone
that is
coming.
Triptis.
She can take it out. That iPhone.
Yeah.
And
Okay, go ahead. Yeah, good. Okay, go ahead.
So the case presentation is as follows. Sir, can you please put the previous slide once?
Yeah, 1 minute.
So, like I said, it is a case presentation on subarachnoid hemorrhage. I've taken this case from Medicover Hospital. This patient is a 54-year-old male patient who presented to the emergency department with the chief complaints of he had sudden loss of consciousness. He presented with 2 episodes of seizure along with vomiting. On arrival, his Glasgow Coma scale was E2, V2, M2. And as a result of which the patient was immediately intubated in view of low GCS. Because there was low GCS, there was lots of airway protection, anticipated airway protection, and he was immediately intubated. Now coming to the history of presenting illness. This episode happened on 25th of July. So, sir, next slide, please. So this episode happened on at 9 p.m. approximately on 25th of July. The patient had sudden loss of consciousness, followed by 3 episodes of seizures. He also had vomitings and abnormal breathing since 9 p.m. He also had involuntary micturition, an episode of involuntary micturition. The patient attendants had given that the patient was having headache present on and off since 3 days. No other significant complaints were present in the patient. So these are the major, so next slide please. So these are the major complaints with which the patient presented to the hospital. But the one is loss of consciousness, seizures, vomiting, and involuntary micturition. Coming to the past history of the patient, he had undergone laparoscopic cholecystectomy for CVD exploration. He was a known case of hypertension, but he was not on using any kind of medication. And the attendants had also not given any significant medication history. Patient was not known to have any other significant illness like diabetes or any other illnesses. Coming to relevant past history, he was a known smoker, but he had quit smoking about a year ago.
Sir, excuse me, Tripti ma'am. So is just a whole second. Achut sir, can we ask questions in between, or should we take the questions at the end?
Questions. Let her complete the history part, and then we shall ask the questions.
I think after the present illness, we can make some questions, I think, if you are okay with that.
Yeah. Yes. So, Tripti, are you done with your history, past history? Let us complete this part, Srinivas.
Okay, sir.
Okay.
Okay, sir. Sure, sure.
Okay. Tripti, go ahead.
Okay, so continuing with the present, with the past history, relevant past history of the patient. He was a known smoker, but he had quit smoking about a year ago. He was an occasional, he used to take alcohol occasionally, maybe like social drinking. He had no other food or medication allergic history present. He had good appetite, his bowels and bladder habits were regular, and also the good sleep hygiene was maintained. Next slide, please. So on arrival, when the patient
Can you please hold on, Tripti? Srinivas, you
Sir.
had some question. Yeah, go ahead with your question, please.
Yeah. Sir, can you go to the previous slides, please?
Which one?
Yeah, it's okay. Past history. Past history. Okay. So, is there any relevance of hypertension and smoking on SAH?
Yes, sir.
1 minute. Tripti, 1 minute. This discussion we shall do that at the after the presentation. Once we start case discussion, we'll do this, Srinivas. Okay.
Okay, sir. Sure,
Yeah,
sure.
right. Okay. Yeah. Go ahead.
అన్ని స్లైడ్స్ వెనక్కి అందరికి పంపించాలేమో కదా అచ్యుత్?
Change చేశాను సార్.
We need to change again. Okay, no problem. Right.
ఇప్పుడు ఏమొచ్చింది? వైటల్స్ అని వచ్చిందా?
Yes, sir. We are at the vitals on arrival.
Yeah. Okay, go ahead.
So on arrival, the patient had a temperature of about 98.6 degrees Fahrenheit. Since he had come with very low GCS, ER people had immediately intubated him in view of loss of airtip protection and secondary lung protection. They had intubated him. His SpO2 was being maintained at 98% with ET tube in situ. The pulse rate was high, around 128 beats per minute. BP recorded was 210 by 130 millimeters of mercury. ABG was 7.37 pH, PCO2 of 25, PO2 of 99, and bicarb of 22. The lactates were 6 millimoles per liter, and GRBS was 210 milligrams per deciliter on arrival. Next slide, sir. So coming to the general examination of the patient. Patient was intubated and connected to the mechanical ventilator. Very beginning, like I had mentioned, the patient was intubated. He was moderately built and well nourished. On examination, there were no signs of pallor or cyanosis, icterus or clubbing or pedal edema in him. Next slide. When systemic examination was done, the GCS was E2, V2, M2 grading. The World Federation Neurosurgical score was 5. Hunt and Hess score was 4. And this was done actually after WFNS and score was done, but this was done just as a provisional diagnosis. WFNS score and Hunt and Hess score was 4. The pupils were anisocoria was present. The right pupil was 3 millimeters reacting well to light, but the left was sluggish. Power, they were unable to assess the power because the patient was sedated in view of intubation. Bilateral, the plantar was flexor, and deep tendon reflexes were both biceps, triceps, supinator, knee and ankle. Right and left were 1+. Coming to the CVS cardiovascular examination, both heart sounds were heard and there were no murmurs present. Bilateral, the lungs air entry was present, but basal crypts were noted in this patient. Per abdomen was soft, bowel sounds were present, and renal, the output was adequate. Next slide, sir. So immediately, the patient was.
Achut sir, any provisional diagnosis with the history and examination part?
Yes, sir.
Yeah, please go ahead, Tripti. What is your provisional diagnosis at this point?
So at this point, because the patient had presented with acute, sudden, severe headache, on and off headache with loss of consciousness and vomiting. So provisional diagnosis is probably subarachnoid
Whoever it is, can you please mute your mics, please? Someone, I request everyone to mute your mics unless you intend to speak on this forum. Okay? Yeah, please go ahead, Tripti.
So because the patient had come with presenting symptoms of acute headache, acute severe headache, probably a lot associated with the raised ICP, vomitings and seizures. Probably it is a case of intracranial bleeding, probably aneurysmal subarachnoid hemorrhage with the intraventricular bleed. That is the provisional diagnosis, sir.
Can I ask you one question?
What to different?
Yeah. What are your differentials for this?
Sir, differential diagnosis would be all the conditions which would mimic subarachnoid hemorrhage, like aseptic meningitis, because meningismus is also present in subarachnoid hemorrhage, cluster headache.
No, why did you come to a diagnosis of SAH without a CT?
No, sir. I will come to that, sir. CT was done in this case.
No. I'm asking if you have seen the patient in ER. So how can you make a diagnosis without CT that it is an SAH?
Probably, usually because of the nature of presenting complaints of the patient, sir. He had come with acute severe headache, which was on and off since past 3 days. Clinical history was such.
Tripti, instead of that, how to you are telling about the only bleeding. Is it a subarachnoid hemorrhage? What is the difference? How to differentiate what Dr. Simas is asking? When you think is subarachnoid hemorrhage, is it a subarachnoid hemorrhage? And the any hemorrhage in the brain? How to differentiate it between clinically? Clinically, you can differentiate subarachnoid or some intracerebral bleed. You say so many cases are intracerebral bleed. How to differentiate between subarachnoid and the clinically before you going for a CT? How to diagnose difference between the subarachnoid hemorrhage, intracerebral bleed?
Right. Tripti, 1 minute. I'll ask you question by question. So, which system do you think is affected in this patient?
The CNS, sir.
CNS. Why do you think so?
Because there was the patient had a headache, the patient had seizures, and the patient had probably vomitings because of raised intracranial pressure.
Right. Okay. And then, so you want to call it a CNS disorder? And then what CNS disorder?
Sir, probably it is a hemorrhagic.
It's a CVA. Could be
CVA,
CVA.
sir.
or
Yes, sir.
Some signs of meningitis or meningism, right?
Yes, sir. Yes,
So
sir.
why? So CVA. So why do you want to call it a hemorrhage? Or can you call it a hemorrhage or infarct? Can you differentiate based on history?
Based on history, it is not very easy. It's difficult to distinguish between hemorrhage and ischemic stroke and hemorrhagic stroke.
Yeah.
Sir.
So that is there. So what are you?
Why not Trupti? How to the presentation? Is it infarct and the hemorrhage? Both are same. There is something difference. Definitely, you should clinically you can differentiate the infarct and the bleed. The onset, and the loss of sensation, loss of consciousness is which is common in a. Is it a bleed or is it an infarct?
Sir, in a intracerebral hemorrhage, there is altered level of consciousness, sir. In infarct, there is usually hemiparesis.
Yeah. That is the most important. You can, you can clinically you can suspect.
Yes. Weakness
Good.
or numbness is there, hemiparesis in ischemia, sir, compared to hemorrhage.
Okay. So you know that it's CVA and more likely it could be a hemorrhage, right?
Yes, sir. Yes,
And
sir.
then can you differentiate whether it is intracerebral bleed or subarachnoid hemorrhage based on the history?
Based on the history, it is difficult to diagnose, sir, between intracerebral bleed or hemorrhage. One thing we can ask is if the patient was on any kind of anti-platelets or anticoagulants.
Have you asked that question?
Yes, sir, I have asked the
Okay.
patient.
So
Yes,
then, so you have a differential, but there one part of information history that patient had a severe headache and
Yes,
sudden
sir.
onset of headache.
Yes,
That
sir.
might point your diagnosis to a subarachnoid hemorrhage.
Yes, sir. Yes,
But
sir.
and what are the list of possibilities that you have at the end of this history?
List of possibilities are probably like I said, hypertensive emergencies or intracranial hemorrhage, aseptic meningitis, cluster headache, because in both these meningismus is present like in case of subarachnoid hemorrhage. Then migraine headache where aura is also aura and may be present. So these are encephalitis. These are all the various differential diagnoses of subarachnoid hemorrhage. So, aseptic meningitis, cluster headache, encephalitis, hypertensive emergencies, intracranial hemorrhage, meningitis, migraine headache. These are all the various other possibilities. Sir.
Right. At this point, any questions from the audience?
Sir, actually, I want to ask 3 questions. Dr. Tretel,
can you please identify yourself?
I am Dr. Radhakrishnan. I am Dr. Radhakrishnan from King's Hospital. I just want to ask you just few questions.
Yeah.
Yes,
so this is basically a case of coma. The patient is basically comatose. So we don't know where exactly is the etiology. So if the patient is comatose, in your examination, since you know it is mostly immunological, what ideally do that? Because GCS you said it's E2, BT, and M2.
Yes,
do you want to go forward with a cranial nerve examination at least of the 9, 10? So at least localize whether the
So cranial nerve examinations should actually be done because focal nerve, cranial nerve deficits are common.
Ravikrishna, do you what's the other question? Hello?
Sir, I'm unable to clearly hear your question, sir. I'm sorry.
Can you please repeat your question, Ravikrishna?
Yeah.
Sir,
Ravi, your voice is breaking.
Your speaker is not good. Yeah.
One minute, sir, I'll switch device and then ask.
Yeah, any other question?
Hello. Sir, I'm Dr. Ganesh. Hello.
Ganesh. Yeah, go ahead, Ganesh.
Sir, what are the differential diagnosis of this patient? And how do you differentiate between hyperacute, acute, and subacute and chronic patient approaching with comatose patients?
Differential
like I said, the
has been mentioned.
Audible, sir?
Still not clear, Krishna.
Am I audible, sir?
Now better. Ganesh, the question to
Am
your
I-
question has been answered. I think earlier she has presented the list of her differentials.
Achyut,
Yeah.
అంటే better to go ahead and anyone you can type their questions in the chat box.
Probably that would be better. Yeah.
At the end of the day, Dr. Achyut
At
will
the end of the
again
session, I'll ask the question.
so that we can smoothly go ahead.
Yeah.
Huh?
We
Okay,
will complete the case. Yeah.
okay.
Go ahead, Tripti.
Yes, sir. So going ahead with the systemic examination of the patient, on examination of the central nervous system, the Glasgow Coma scale was 6, which was E2, V2, and M2. There was anisocoria of the pupils, with the right pupil 3 millimeters in diameter reacting to light. The left was sluggish. Power was unable, we were unable to assess the power due to sedation. The patient was sedated in view of intubation. Bilateral, the plantar was flexor. Deep tendon reflexes, biceps, triceps, supinator, knee, and ankle both were 1+. The CVS, both S1 and S2 was heard. No murmurs were present. Respiratory bilateral air entry was present, but basal crypts were found. Per abdomen, soft. Per abdomen was soft, and bowel sounds were present, and urine output was adequate. So coming to the investigations, immediate investigations like blood profile of the patient, including the neurosurgical profile, the ABG, chest X-ray were done, ECG was done. Later on, a 2D echo was sent to. The patient was first sent for CT of the brain, HRCT chest in view of basal crepitations, and also the patient was taken for CT angiogram. So the investigation profile is as follows. Next. The HP was 18.8 grams with PCV of 58. Total counts for 20,000 raised, 20,800. The RBS was also high, which was 297 milligrams per deciliter. Platelets were adequate, 3.8 lakhs. The serum electrolytes were almost within normal limits, which is 133 sodium, 4.5 potassium, and 99 chloride. LFT was within normal limits. Serum creatinine was 1.3, blood urea was 55, INR was 1.1. 2D echo, there were no regional motion wall abnormalities, and the EF was 60%. Basically, it was normal, sir. So this is the chest X-ray of the patient, and this is the CT scan of the patient. Next. So this is the CT of the patient, sir. As we can see, CT angio is also done, and in CT angio, and in the anterior circulation, ACOM aneurysmal artery rupture was present with the intraventricular hemorrhage. So, and blood was present in the basal cisterns. Blood present in the basal cisterns. This was the HRCT chest, sir. In the HRCT chest, bilateral basal atelectatic changes or query aspiration pneumonia is aspiration is present, sir. So the diagnosis on CT scan was
so 87 cases you have faced.
Hello. Yeah.
But you are getting claim rate only for single number, single digit.
Go ahead, Tripti.
So continuing with the diagnosis on CT scan, the CT scan showed anterior communicating artery aneurysmal rupture with subarachnoid hemorrhage with intraventricular hemorrhage, and mild aspiration pneumonia was noted in HRCT chest. So this was the diagnosis based on CT scan. Coming to the treatment which was started in the ER, the patient was put on mannitol 100 ml IV stat, Levipil 1.5 grams IV stat, Pantop 40 mg was given, gastro prophylaxis in the form of Pantop, Zofor 4 mg IV stat was given, Labetalol 20 mg IV stat, Nemotipin was started, 60 milligrams stat, and fluids were NS at the rate of 100 ml per hour, and antibiotic Monosub 1 gram IV stat was given in the ER.
Okay, Tripti, we'll stop here. We'll stop
Yes.
here for a moment. Okay.
Yes. Yes.
So if you have the clinical suspicion of subarachnoid hemorrhage or some intracranial hemorrhage, and then most likely subarachnoid hemorrhage, and then you got a CT scan done. So if you have to go, you have mentioned the list of investigations that you would do. What are the, and it's a big list. So what is the first investigation of choice in this patient? Only one radiological investigation if you want, if you can ask for.
So the first investigation of choice would be a plain CT scan, sir, non-contrast CT scan, as it would show the subarachnoid bleed.
So it
As
would
it is
show, no, it would show whether there is a bleed
or infarct.
bleed or not, then
Yes.
location of the bleed and
Yes.
the nature of the bleed also, right? And
Right.
then, so based on that, you can decide whether it is a subarachnoid hemorrhage or intracerebral hemorrhage or no hemorrhage at all. Okay.
Right. Right.
Then what would be your investigation of choice further? After the CT, plain CT of brain, what would you go for?
Sir, after plain CT of brain, the level 1 recommendation is, if the CT scan shows subarachnoid hemorrhage, if it is confirmative, then there is no need of further investigations. If non-contrast CT scan is not very clear of a subarachnoid hemorrhage, then class 1 recommendation is to do a lumbar puncture.
No. Wait a minute. Once you are done with plain CT of chest and of brain, and then
Yes,
there is a bleed, then you would have to go for CT angiogram.
Angiogram is, yes, sir. That is the gold
Yes.
standard, sir.
Gold standard
of 4-vessel CT digital subtraction angiography or CT angiogram is the gold standard, sir. If non-CT scan is not.
And what information would you expect from CT angio?
With
of
CT
brain?
angio, we will be clearly able to see the 3-dimensional view of the blood vasculature, blood-brain vasculature. We will be able to see the location of the aneurysm, as well as the extent to which, how to approach the surgery, extent, all these things we will be able to see in digital subtraction angiographies.
Right. So let's assume that this patient had, we know that this patient had subarachnoid hemorrhage, and also you had a CT angio done, and that shows aneurysm in the anterior circulation, right?
Yes.
And
yes.
where is that aneurysm?
Here also it is there in the anterior circulation only, sir.
So anterior communicating artery aneurysm,
yes,
which
sir.
ruptured and led to subarachnoid hemorrhage, and
Yes.
also intraventricular extension, right?
Right.
Okay. So you are the PG, you are the resident attending this patient in the emergency.
Yes.
So what is the resuscitative aspect that you would undertake at this point of time?
So the resuscitative aspect is, the first thing is for every patient who comes to the emergency, we have to look for airway, breathing, and circulation, sir. In this patient, because he had presented with low GCS, which is E2, V2, and M2, GC of less than 8, there was loss of protective airway reflexes, so he was intubated in view of low GCS. Rapid sequence
How soon
intubation
should
was
you
done.
intubate the patient? And like before the radiological imaging or after the radiological imaging?
So before the radiological imaging itself, it is prudent to intubate this patient because he may deteriorate at the time of radiological investigations like CT or MRI. So as such, the patient is having low GCS. One is to protect his airway. We have to intubate the patient to make sure that he does not crash at the time of investigation.
Wait a minute. So here it's ABC and resuscitation phase. Okay. So when irrespective of the diagnosis and irrespective of the diagnostic workup you're planning, forget about what is going to happen next. But at that moment of time, you're supposed to secure the airway, right?
Yes, sir.
So the answer you should give for this question is, because the patient's airway is compromised, you would straight away go for intubating the patient. Okay.
Yes.
Okay. So what are the precautions that you should have to take while intubating this patient?
Since this patient had come, we don't know the fasting status of the patient, and he had come in emergency. We have to do a rapid sequence intubation, sir. And also because we don't want any kind of hemodynamic response with intubation, which might further raise the intracranial pressure and cause further rupture of the subarachnoid aneurysm. Can cause further hemorrhage. We have to blunt the airway responses. So we have to sedate the patient and then go for rapid sequence intubation.
Yeah. So what is your technique of rapid sequence intubation for this patient? What are the drugs you would use?
So in this patient, we would go for we can go for rocuronium, and we can give fentanyl. First is we can give glycopyrrolate followed by fentanyl of 100 mics. Then propofol of because the BP is high, we can go for propofol, intubating dose of about 100 to 120 milligrams. Then after that, we can, because scoline will raise the intracranial pressure, we can go for with rocuronium, sir. And we need to put 7 C's we have to follow. We have to put pressure, Felix maneuver, and we have to intubate this patient.
So why do you want to give glycopyrrolate here?
To control the airway secretions.
Okay. So you don't have to use glycopyrrolate here. Probably the old school of thought we used to use anticholinergics. Now we don't have to, because it can cause rapid tachycardia, number one, right? And then propofol is not a bad choice. You can go for propofol, but you have to titrate the dose, because you don't have to, you don't want to drop the blood pressure drastically, right? And you said that you don't want to give scoline because it would cause fasciculation and corresponding increase in the intracranial pressure, right? And you chose rocuronium because it would give early intubating conditions, and there won't be fasciculations and no corresponding increase in the intracranial pressure. Okay. And you also mentioned about cricoid pressure. Okay. So then you would go for smooth rapid sequence intubation and secure the airway, right? Okay. And then you would think of the stabilizing in terms of A, done, B, you would put him on ventilation, and C, right? C, what are your concerns here as far as C is concerned before you go to the radiological imaging?
Yes, sir. The concerns would be, one is the patient may be in hypovolemic status, or we have to maintain euvolemia, sir. We have to.
See, that is fluid, right? Before that, I would like you to comment on the heart rate and blood pressure, right?
Yes.
On C part, the cardiac part. So what is the heart rate will be like? What was the heart rate, presenting heart rate?
The presenting heart rate was high, sir, in this patient. The patient was having a heart rate of about 128 beats per minute.
Right. You don't want to increase it further, or if possible, you want to get it to less than 100 by hemodynamic stabilization, right?
Yes.
And the blood pressure was what on admission? What was the blood pressure?
It was also high, sir. The blood pressure was about 210 by 130 millimeters of mercury, sir, which was also high. So it would cause a strain on the heart. So we have to give adequate analgesia, sedation to blunt
that
the
again,
pain.
it cause what? Pain on the heart.
Yes, sir. It would cause strain on the heart.
Strain on the
Uh,
heart. Okay.
Yes,
Okay.
sir.
Right. Yeah.
Yes,
And
sir.
what else?
Because,
What else? You were suspecting subarachnoid hemorrhage and the
yes,
blood
sir.
pressure. So if there is subarachnoid hemorrhage and the blood pressure is, what is your blood pressure target?
The blood pressure target should be, there's not a particular target, but usually the American Society of Anesthesia, the American Society of recommends that the target should be less, systolic should be less than 160 millimeters of mercury, sir, to prevent further rebleeding episodes or to further increase the rupture, to prevent the rupture. So systolic blood pressure is mainly targeted here to
And
be
your
controlled.
target systolic blood pressure is less than what?
160 millimeters of
Less than
mercury.
160. And your patient's blood pressure is 230 millimeters of mercury.
Yes, sir. Mainly the mean has to be reduced to around less than 110 millimeters of mercury.
So how do you do that here?
Mainly in these patients, it is important that we avoid vasodilators like NTG because it will further increase the
Here, 1 minute, Tripti. You have your blood pressure is 230 or 130 or something, and your target blood pressure is less than 160, right?
Yes, sir.
And you're anesthetizing the patient here.
Yes, sir.
So anesthetizing the patient would have dropped the blood pressure down.
Right, sir. Right,
And
sir.
after sedating and relaxing the patient, if the blood pressure is less than 160, you don't
Correct.
have to do anything at this point, right?
Right.
The thing is, you have to maintain anesthesia till the further investigation is done, right? You may not have to go for any other drug modalities,
Right,
right?
sir. Right,
Okay,
sir.
and we'll stop at this point. Okay.
Okay.
So
Okay.
we have resuscitated the patient, and then you plan to take the patient for CT scan, right?
Right, sir.
What sort of monitoring would you do on this patient when you go for the CT scan?
So, when we go for CT scan, we have to do basic monitoring, sir, like pulse oximeter, then BP monitoring, respiratory rate, and also clinically assess the patient, keep on assessing the patient.
What do you mean by monitoring respiratory rate here? Your patient is on ventilator, right?
Yes, sir. Yes,
Would
sir.
you take the patient on transport ventilator or other modalities of ventilation?
It would be better to take the patient on transport
If
ventilator.
available, you
If
prefer
it is available.
patient on a transport ventilator.
Yes, sir.
Not
Yes, sir.
available, then you would compromise with some sort of vein circuit ventilation
Yes. Yes,
or
sir.
ambu ventilation.
Yes,
But
sir.
ambu
With ambu.
because you may not be able to give enough of PEEP, you would choose vein circuit ventilation, right?
Yes.
What is the advantage of ambu over vein?
Advantage of ambu over veins, sir.
So you don't need to depend on oxygen supply if you're using ambu bag, right?
Right,
When
sir. 21%.
even if there is no problem with oxygen source, you can still ventilate the patient with room air, right? That is the advantage. And vein circuit advantage is you can give enough of PEEP as much as you think or you want, okay? But it needs continuous supply of oxygen,
Yes.
right? But the best is transporting the patient on a transport ventilator.
Right.
So the monitoring is SpO2, pulse rate, ECG, and then blood pressure.
Blood pressure.
Okay? Blood pressure, how frequently do you measure? At least 5 minutes, or if not feasible, you can go for 10-minute automated cycling, right?
Right.
Okay. And then you have to make sure that your tube is secured.
Yes, sir.
Individual tube is secured. Okay.
Right.
And then you have got the imaging done.
Right.
Okay. In no time, because we already had the scan, and you got the diagnosis of subarachnoid hemorrhage with anterior communicating artery aneurysm, which ruptured, causing subarachnoid hemorrhage,
Yes.
right? And intraventricular extension. And also, why did you get the HRCT done? You mentioned HRCT initially. Why did you get it done?
So the patient had come with the episodes of vomiting, sir. And there was concern that probably he had aspirated. His breathing pattern was also abnormal when he had come to the ER. So probably because of um, uh, there might have been aspiration, and also the PO2 was 99 only in this patient with abnormal breathing, and on auscultation bilaterally air entry was present, but basal crypts were present.
So you
So
were
that
you were suspecting aspiration, and hence you wanted to get a HRCT
HRT.
test done, right?
Yes,
Is it necessary at that point of time, or could you have waited for some more time?
could have waited for some more time, sir, because as such there were basal crypts on both the sides. Better to go for ABC and then blood pressure, target blood pressure management and all.
Yeah.
And then
So
once the patient is stabilized, then we could have taken the patient.
right,
HRT.
okay. So HRCT could have waited, but it depends on the institutional protocol. There is nothing wrong in getting done, but it was probably sort of okay. You have assumed and then you got it done.
Yes,
That is no problem. But basic radiological imaging would concentrate on the brain part of it. Okay. And
right.
then what sort of blood tests you want to do in this patient? You said
So
neurological profile. That may not mean anything to others because it is institutional, right?
yes,
So you have to mention the individual tests you want to see rather than any profile. Okay.
yes.
Yeah. So what are the tests you want to do in this patient?
One is complete blood picture, sir, which would give us the HB status and PCV value, total counts. Then the RBS, because it is important to maintain euglycemia, and also hypoglycemia is one of the mimics, stroke mimics. Then we have to see if there are any kind of serum electrolyte abnormalities, because hyponatremia, hypernatremia are common presentations. But at the time of presentation, it's just as a baseline investigation, we have to get serum electrolytes, liver function tests to see if there is any coagulation abnormalities, if the patient is on antiplatelets or anticoagulants. A baseline RFT has to be done, sir.
Tripti, for this question, what would be your concerns before you ask for the blood test? So you would be concerned about the coagulopathy, right?
Yes, sir. Yes, sir.
And anemia.
Yes,
Why
sir.
did you want to ask for total leukocyte count in this patient?
Total leukocyte count, because there is the differential diagnosis of meningitis also is one of the differential diagnosis. So if there is
infective pathology and non-infective pathology, number
yes,
one, right?
yes,
And and the other point is, even in subarachnoid hemorrhage, there can be reactive leukocytosis, right?
yes, right.
Okay, so that is the answer. And why did you want to check hemoglobin?
Because increase in hemoglobin is associated with sluggish blood flow, sir, and it is one of the parameters we to dilute. Hemodilution is one of the triple H therapies of vasospasm, sir.
No, I
So
think see anemia here.
anemia also, yes, sir, right? Anemia.
HB here, because your concern is hemorrhage, right?
Yes.
More anemia or less hemoglobin, and they're at increased risk of hemorrhage. Okay. Leukocytosis, high hemoglobin is not a problem, not a risk factor for hemorrhage here. Okay. And that
Right.
is for venous thrombosis or other thrombotic diseases. Okay. Okay. And then why RFTs and electrolytes we know, because we need to know the electrolyte status for management of the intracranial pressure, right? And renal, why did you ask for renal?
Renal is because urine out to assess the renal status of the patient, sir, because later on we might have
You
to
want
give
to know the baseline renal function,
yes,
right?
sir.
And coagulopathy, did you ask for, did you say coagulopathy?
Yes, sir. PT-INR was done in this patient, sir. Yes.
Why? Why do you have to get PT-INR done?
If there was any coagulation abnormality leading to the intracranial hemorrhage or bleed, to differentiate between IC bleed and
that is number one. And any more?
Also to know the coagulation status of the patient, if there is any deranged coagulation, then we have to arrange for FFPs and
So one, if there is any abnormality, you have to correct it.
correct
Two,
it.
if there is any procedure planned, you need to know the coagulation status of the patient, right? These two are the answers, right? Also, when you ask for CBC, you have to know platelets to know if the patient is coagulopathic,
Yes.
right? And
Right.
why you ask for LFTs also, right?
Yes, sir. LFTs also.
Why?
Because LFTs, like routine baseline investigations, we have to know before proceeding if there are any.
You have to. It's not just a routine baseline investigation. Because deranged LFTs are associated with coagulopathy usually,
Coagulopathy. Yes, sir.
right?
Deranged
This is the
LFTs.
reason why you want to know whether any liver function tests are abnormal or not. Okay.
Okay.
Right. Okay. So with this, you have completed the initial resuscitation part and diagnostic work,
Yes,
right?
sir.
And at this point of time, what sort of questions will run through your mind?
Sir, immediately we have to contact the ICU team for neuro to shift the patient to neurosurgical ICU care. We also have to inform the neurosurgical team that a case of subarachnoid hemorrhage, which may require
One
surgery.
communication. One communication. Whom all would you like to communicate?
One is to communicate to the critical care intensive
Critical care, neurosurgery, and
neurosurgery, anesthesia for doing PAC if required for
okay, right.
surgery. These three, and also cardiology for doing a 2D echo, probably.
Okay. So the first thing is, along with these people, you are at this point, communication with the family is also important, right?
Yes.
Yeah. So what would you to the family at this point of time when you're seeing this patient?
So we have to assess, once we have assessed the patient, we have to prognosticate the family members regarding the nature of the prognosis in subarachnoid hemorrhage. Mostly, we have to tell them that the patient, many patients, almost 10%
Yeah,
of
okay.
the patients.
So not wasting much time, you have to communicate the diagnosis, okay, in current condition of the patient, and then the treatment plan and possible prognostication.
Yes.
Okay.
Yes.
So 4 points you have to mention, and you have to and also in a private setup, you have to probably alert them about the financial requirement also.
Yes.
Right? Is it an insurance or cash or cashless or whatever? Fine. Okay. And in the history, you were mentioning about WFNS and Hunter and Hess trading. Okay.
Yes, sir. Yes,
and
sir.
what are they? How are they relevant here?
One is it helps in the prognosis and grading of subarachnoid hemorrhage, sir. The Hunt and Hess grading system is no longer used now, but still we can grade the patient based on the symptoms with which he presents. The Hunt and Hess classification, which is stage one, grade 1 is asymptomatic or patient presents with a mild headache. Grade 2 is moderate to severe headache, and the patient has nuchal rigidity and may even present with focal neurological deficits or cranial nerve palsies. Then grade 3 is the patient is confused, lethargic, and he has mild focal neurological deficit. 4 is stuporous or yes, sir. 4 is stuporous or hemiparesis. 5 is comatose or posturing. Then the WFNS scoring scale is like it's based on the Glasgow comma scale. Here in our patient, the WFNS scale is 5 because his GCS is is around 6, which is less than 7. Coming to the WFNS scale, grade 1 is GCS 15 and the patient has no motor deficit. Grade 2 is GCS 13 to 14, without any motor deficit. Grade 3 is 13 to 14 GCS or there is associated motor deficit, and grade 4 and 5 are actually, they have bad prognosis. It means that the patient is critical. The scaling is inversely proportional to the prognosis of the patient, and grades 4 is 7 to 12 GCS, and grade 5, which is our patient, which is less than 7, which is 3 to 6 GCS. So that is the WFNS scale of the patient.
Right. So this is useful in prognosticating and also communicating with various teams, the medical teams, and also with the family, right?
Yes.
So are there any other grades that you can think of apart from H&H and WFNS?
Yes, sir. There is a CT grading also, which is the Fisher scale. There are two scales, which is Fisher scale, and now we are using the modified Fisher scale, which is based on the CT appearance of subarachnoid hemorrhage. Grade 0 is the CT does not show any kind of subarachnoid hemorrhage or intraventricular hemorrhage. Grade 1 is minimal SAH, but and there is no intraventricular hemorrhage in both the ventricles. Grade 2, the SAH is minimal, which is less than 1 millimeter in size, but there is bleeding in both. There is hemorrhage in both intraventricular in ventricles. Grade 3, the SAH is the size of the SAH is more than 1 millimeter, which is thick SAH, and there is no intraventricular hemorrhage in both the lateral ventricles. And grade 4 is thick SAH, which is greater than 1 millimeter in size, with the intraventricular hemorrhage in both the lateral ventricles. So this is the modified Fisher scale.
Right? Have you presented a slide for Fisher scale?
Yes, sir. It is there in the next slide, sir.
Okay.
You can just go to the next slide.
Yeah, Fisher grading system, right? Yeah.
Yes, sir. This is the Fisher grading system.
Yeah, right. Okay. So you know what you're dealing with. Number one, you have to communicate it with the neurosurgeons, critical care, anesthesia, cardiology, etc., and the family, most importantly, right?
Yes.
And then the place of management of this patient. You're still in the ER.
Right.
So where do you take this patient? And one more thing, would you think about any other specialists that you would need in managing subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage?
The radiological intervention may be needed because
radiology is also, you would think of specialty available for that specialty, right? And what else did you say last?
So in view of, we should also think about radiological intervention in the form of endovascular procedures, sir. So that's why.
So these are all the specialties that you would think of at this point. You may need the help of, right? So you're still in the ER. Where would you take the patient from here?
So we have to communicate for specialized neuro care for this patient, sir. So a bed in neuro ICU has to be communicated for this patient.
So you would transport the patient to the neuro ICU.
Neuro ICU, sir.
Stabilize the patient there, right?
Right. Yes.
What are your goals? What are your goals here after reaching the neuro ICU as an intensivist? What are your treatment goals here?
So the first thing is we have to make sure that the patient has complete bed rest, sir. The patient has bed rest.
What do you mean by complete bed rest?
The patient should not have any kind of stimulation so as to cause further rupture or rebleed of the aneurysm, sir. The patient.
So you anesthetize, that is sedate and paralyze the patient.
Right, sir. Sedate and paralyze the patient, put the patient on mechanical ventilator, make sure that he does not buck or there is no stimulation which will further increase his vital, like pulse rate, or deteriorate the present condition of the patient. So complete analgesia, sedation and paralysis. Patient should be put on mechanical ventilator. With the head up, there should be head up position of 30 to 45 degrees. Then the patient, there should also be other parameters which should be monitored. All the routine monitoring monitors should be attached to the patient. DVT prophylaxis in the form of compression on pneumatic stockings have to be put. GI prophylaxis, stool softener, so that the patient does not have to strain during the stool
Yeah,
or
fine.
is not
So
constipated.
here, sedation, what agents would you choose?
So fentanyl, midazolam and fentanyl are the agents which is
Why
used.
midazolam? Why midazolam?
Midazolam, if the patient has any kind of, if the patient is conscious, no, not conscious. One is to seizure prophylaxis, midazolam will help. Seizure prophylaxis is not indicated usually, but anxiolytic.
Had seizures, right?
Sir?
In the history, this patient had seizures, right?
Yes, sir. In the history, the patient had
So
seizures.
he is no more a prophylaxis patient. He is a treatment patient. Patient
Right.
needs anti-epileptic drug.
Yes,
Okay.
sir. Yes,
Okay,
sir.
that's number one. So midazolam, I would not go for midazolam because of whatever delirium and the recent studies against midazolam. So you have proper anesthetic drugs because you need a sedated, comfortable patient who is not bucking on his endotracheal tube. Okay. So good analgesia and then good sedation and good muscle relaxation. Right. So analgesia, you can go for fentanyl or morphine, but fentanyl is chosen, preferred over morphine. And then propofol is not a bad choice, but you have to be concerned about the hypotension. So cautious about hypotension and go for propofol infusion. And how do you want to sedate this patient, paralyze this patient?
Vecuronium, sir. Vecuronium, because it is cardiac stable and also it is long acting. So vecuronium, the choice would be vecuronium in this patient. Sir.
How? How do you want to administer it?
Sir, first loading dose of first we will give loading dose, sir, followed by 2 to 4 ml per hour, sir. 4 ml per hour.
You need to tell the dose in milligrams per minute or milligrams per hour with in relation with the body weight. Okay, so nothing wrong in choosing vecuronium and even atracurium. Some muscle relaxant is acceptable here, right? Okay, so but the point here is it's not boluses, but it is infusion.
Infusions.
Because you don't want the patient to cough on the tube or buck on the tube between your boluses, right?
Right.
And why do you want to go for head up position here?
To reduce the intracranial pressure, sir. To reduce the ICP.
Right. How does it help with reducing intracranial pressure?
It helps by keeping the neck in neutral position and keeping the head in neutral position, and also it decreases the venous return.
Okay. It increases the venous return if you put the patient in head up position. Thus helps in reducing the intracranial pressure. Clear?
Okay, sir.
Yeah. So 30 to 45 degrees, that helps in reducing the intracranial pressure, and hence you would usually go for head up position, right? Like in any other ICU patient, more so in neuro patients, right? And then what are your further plan? Like what sort of lines and monitoring would you go for on the ICU?
Sir, this patient, because he is in a critical condition, one is he is in the neuro ICU. There should be, like you said, continuous monitoring of all the vital parameters, including the pulse oximetry, the pulse rate, the blood pressure. If the patient is being administered infusions of for reducing the blood pressure, then maybe IABP monitoring also might be required. And because the
What is that?
Intra-arterial blood pressure monitoring.
Right. Okay.
Then patient has to be maintained in euvolemic status. So,
what line do you want to go for? A central line do you want?
Yes, sir. A peripheral line and a central line also.
Why a peripheral line and why do you want a central line?
Sir, central line access is for maintaining for administering any kind of antibiotic or vasopressors, vasodilators. All these central line access is important, sir, in this patient. Also, the patient might go in for surgery and anticipated complications later on. So, central venous access is required in this patient.
Okay. Why peripheral line?
Initially, before securing the central line, peripheral line is secured, sir, in the ER itself for administration of drugs for anesthesia and
Okay.
intubation
So
purposes.
what do you want to do with peripheral line? You want to continue it or remove it after securing the central line?
Usually, central line, once it is secured, then peripheral line is not used in a
Okay. So you can remove the peripheral line
remove
once
the peripheral line.
you secure the central line. Okay. So the
Yes.
answer for central line is like you have multiple drugs going, so you need multiple venous access.
Yes.
That is one solution. And also you would be sampling patients' blood multiple times. So
Yes.
central line gives that access. In
Yes.
D, you may give the vasoirritant,
Vasodilator.
vasoirritant or highly concentrated medication like mannitol, 3% NaCl, or vasopressors or vasodilators, etc., etc. So you need central venous access for these 3-4 reasons, right?
Yes.
So
Yes.
now my question is, which site is preferred for central venous access?
For this patient, sir?
Yes.
For jugular, sir?
Okay.
Then subclavian, sir. But in view of possible coagulation disturbances, jugular is preferred in this patient.
Yes. Jugular is
According to the expertise of the.
Yeah, and because the patient may end up having vascular interventions and heparin, so
Yes, sir.
better would be to go for a jugular. And the
Yes.
concern usually is expressed is the obstructed venous drainage from the brain. Is
Yes.
it your concern too, or you're not concerned about it?
Concern, sir, the patient should, there should not be any bending of the neck. It should be in.
Okay, so
straight
going
forward.
for jugular is not a problem. And even if the patient is having high intracranial pressure, putting a jugular venous catheter is not a contraindication. Okay, that's what I'm trying to say. Okay, right? And
Right.
the bigger problem is, as you mentioned, venous obstruction or pressure on the neck vein,
Yes, sir.
and not the catheter inside the neck veins, right?
Yes. Right.
So you should make sure that the endotracheal tube tie is not tight on the neck vessels, right?
Right.
Okay. That is a bigger problem than something like a catheter here. Clear?
Yes.
And
Yes,
what
sir.
else? What else would you do?
The Riles tube insertion is
And
mandatory.
Riles tube insertion, usually we put the Riles tube at the time of
Yeah.
itself.
Yeah.
Okay. So yes, that is definitely required for nutrition.
Yes,
right?
sir.
Okay.
Yes, sir.
And what about the arterial pressure monitoring?
Yes, sir. Arterial pressure monitoring also has to be secured because this patient has high blood pressures and we may have to give infusions of short.
Site selection.
Yes, sir. Site
So
selection. The
if
radius.
not, it is definitely required because you will be monitoring the blood pressure closely. Right?
Yes, sir. Yes, sir.
And then which side would you prefer? Would you choose?
Radial, sir. Radial would be preferred.
Why
sir.
radial? Why radial? Why not femoral or something else?
It is more easily accessible and less amount of infection, like infections.
Okay, radial is the most preferred site for arterial cannulation for intra-arterial blood pressure monitoring, right?
Yes.
If
Yes.
not possible, then you can think of femoral or brachial also.
Right.
Femoral, because the neurointervention radiologist may take the femoral axis, you probably can avoid femoral axis for them, right? So
Right.
best radial artery.
Yes.
Right. And then Allen stress, these are all the questions that you would face. Allen stress,
Right.
modified Allen stress. Okay.
Yes. Yes. Sir.
Etc. Why not? Why is radial preferred over brachial?
Right. Sir.
Why is radial preferred over brachial axis?
because there is a collateral circulation which is present, sir, in the palm of the palm. So radial is preferred.
Okay, right. And one question, Dr. Ravi Krishna, what are the indications for angiography in ICH, or routinely you want angio in all cases of ICH? What are the reflexes which have to be elicited in a case of coma patient? Right. Okay. We'll answer your questions, Ravi. I'll ask Tripti to answer these questions. Okay. Right. So you have done the lines, completed the line, and then informed the neurosurgeon or intervention radiologist, etc., etc. Right.
Yes, sir.
So, what are the usual causes of intracranial subarachnoid hemorrhage?
Usual causes of subarachnoid hemorrhage, sir. So the usual causes of subarachnoid hemorrhage most commonly is intracranial aneurysmal rupture, sir.
Okay.
And in that also the anterior circulation aneurysmal rupture is most common. Then the least one is the the posterior circulation, which is 15%. MCA 22% of the times it is involved, sir. Other causes of SAH are AV malformation, then trauma, perimesencephalic arterial dissection, coagulopathy, venous thrombosis, pituitary apoplexy also causes SAH, and reversible cerebral vasoconstriction syndrome, sir. So these are the causes of SAH, and there are risk factors also, which are modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are very low body mass index. Cigarette smoking is one of the major risk factors, along with hypertension, excessive alcohol intake, and also drug abuse such as cocaine use. Non-modifiable risk factors are female sex. The female sex is 1.2 to 1.6 times more prone than the male sex. Increasing age is another non-modifiable risk factors. As the age increases, especially after 50 years of age, the incidence of aneurysmal rupture is more. Size of the aneurysm, the more the size, the greater the chances of rupture. We have to elicit family history because first degree relatives, often the chances of aneurysmal rupture is a very it's a very strong point in history to elicit aneurysmal rupture, family history, first degree relatives, polycystic kidney disease, and also Ehlers-Danlos syndrome, Marfan syndrome, where there is connective tissue abnormality. Also, there is a risk factor for subarachnoid hemorrhage.
Right. Okay.
Yes,
Sorry. Fine. What are the usual management methods at this point of time? What would be the plan for the surgeon or treatment options for this patient, apart from resuscitation and maintenance?
Yes, sir. The first one is, like I have said, ABC, neurosurgical admission, neuro ICU admission. Then informing all the teams, like
No, my question is about the aneurysm management.
Aneurysm management.
Yeah, how do you prevent rebleed, and then how do you deal with the aneurysms, right? So how do you prevent the rebleeds here?
Yes, sir. One is rebleed. Rebleeding is one of the most important complications of aneurysmal subarachnoid hemorrhage. And the first 24 hours are very important for very important, crucial time where rebleeding can happen. So in this situation, we have to maintain we have to make sure that the blood pressure is maintained, sir. One is the systolic blood pressure as per AHA and ASA guidelines have to be maintained, like it has to be controlled below 160 millimeters of mercury. And also we have to start short-acting antihypertensives in these patients. Then nimodipine should be started immediately once the diagnosis of SAH has been made, to prevent vasospasm, which will occur usually few days after SAH, but it continues till 21 days. So the dose of nimodipine, once the patient comes to the ER, is 60 milligrams every 4th hourly to be continued. So these are the drugs which have to be given. Surgical, because this patient has thrown up seizures, here seizure profile, seizure treatment, anti-epileptic treatment has been initiated in this patient. Otherwise, prophylactic seizure therapy is not indicated. Apart from maintaining the blood pressure, systolic blood pressure, giving preventing of rebleeding, and
So you control the blood pressure between less than 160, and you would intervene if it is more than 180, right?
yes, sir.
Right. So what are the options available for you for controlling the blood pressure?
So the options available are, one important thing is
Yeah, go ahead.
so the one important thing is we have to give short-acting antihypertensives. So,
Okay.
which short-acting antihypertensives like labetalol, ismolol, and we have to avoid NTG because it will cause further deterioration of the patient because of increased cerebral perfusion. So, but definitive management,
Right. Okay.
but the definitive management consists of neurosurgical interventions. We have to talk to the neurosurgery surgical team.
So as an intensivist, you have done with you are dealing with the patient like sedated and paralyzed, and then
Right.
maintaining good blood gases so that there is no CO2 retention and no intracranial pressure. Okay.
Yes.
Then intracranial pressure management we have to discuss. Okay. Discuss in
Yes.
the sense what are the options, like what are the various layers of intracranial pressure management, etc., etc. So
Right,
what
sir.
you have increased sedated and paralyzing and head up position, right?
Yes, sir.
And then, what are the drug options that are available for managing intracranial pressure?
So intracranial pressure, we have to the drug options are giving mannitol. One is we have to we can give mannitol, sir, or we can give, one is normal measures like head and
That's all
elevation of the
done.
patient.
Okay. See, your drug options, my question is, you have done 45-degree head and elevation and sedated, paralyzed, and blood gas, the gases are maintained, no CO2 retention. And then the question is about the drug, that is mannitol and 3% NaCl.
Yes.
What are the advantages of mannitol?
The advantages of mannitol are it will cause immediate decrease of the intracranial pressure, sir, and prevent any further rebleeding. It will also cause it will prevent rupture of the aneurysm also.
What are the problems with mannitol?
The problem with mannitol is we have to monitor the urine output because it might cause acute AKI, sir, acute kidney injury.
Why?
How? Sir,
with mannitol, it depends on its action depends on the kidney function, right?
Yes, yes,
okay.
sir.
And then
Yes,
it can cause dangerous hypovolemia also because it's a diuretic drug.
Right, sir.
Also, it can cause electrolyte disturbances. You have to monitor electrolytes when the patient is on mannitol, number one.
Yes, sir.
But
Yes,
it's a
sir.
concentrated medication, it should go through a central line.
Yes, sir. It has.
Right?
Right, sir.
Okay.
Right,
And
sir.
what is the alternative you have for mannitol?
3% NaCl, sir.
3% NaCl. Actually, hypertonic saline, 3% NaCl is what we use here. But in the Western countries, they use 7.5% NaCl. Okay?
Yes, sir.
Okay. So the advantage is it doesn't depend on the renal function for its action. Right?
Yes, sir.
Okay, so you can use 3% NaCl for your patient.
Yes,
Okay.
sir.
Right. So between 3% NaCl and mannitol, it depends on the institutional protocol, what to use, and also the neurosurgeon, right? And some
Right.
people use the combination of both these drugs.
Right, sir.
Okay. Right.
Okay.
And coming to the definitive treatment, what are the options?
So,
Yeah, go ahead.
the definitive treatment consists of obliteration of aneurysm, sir. And
Okay.
it's important that best results are formed when the aneurysmal surgery is done between 24 to 72 hours of the onset of aneurysmal subarachnoid hemorrhage. There are two types of approaches. One is the surgical clipping, which is the microsurgical clipping using titanium clip. It also requires craniotomy. And the second option is endovascular coiling, which is the fluoroscopically navigated microcatheter, and platinum coils are placed in the in the artery. So the recommendations for the 2023 guidelines also suggest that grade 1 recommendation is for patients with aneurysmal subarachnoid hemorrhage, surgical or endovascular treatment of the ruptured aneurysm should be performed as early as feasible after presentation, preferably within 24 hours of onset to improve the outcome. One is before 24 hours, if it is done, it is best. That is grade 1 recommendation. The second one is complete obliteration of the ruptured aneurysm is indicated whenever feasible to reduce the risk of rebleeding and retreatment. That is also grade 1 indication, sir. Then grade 2 indication is for patients with subarachnoid hemorrhage in whom complete obliteration of the ruptured aneurysm is either by clipping or is not feasible, or coiling is not feasible. At least partial obliteration to secure the ruptured site is recommended, sir, so that there is some kind of functional recovery. So, and there were two trials.
Yeah, just let's stop here. At this point, I would ask other moderators in this case discussion, please contribute some questions or discussion. So, Dr. Kuchelbabu, sir.
Yeah.
Sir, any questions?
The questions, what is about the muscle relaxants? How much duration you want to give it? What is the infusion? Is it going to be, is it routine protocol for using the muscle relaxant? How many hours you want to give it? Is it a intubation dose or continuously infuse it for a muscle relaxant on a patient on a ventilator?
Right, sir.
Tripti.
Yes, sir.
What is your answer to this question?
So vecuronium, it should be given only as an infusion, sir, and not as a bolus dose. The muscle relaxant.
No, my question is not the, Tripti, my question is not the infusion or a bolus. Whether
Yes,
you need a muscle relaxant to patient continuously or not.
Not required continuously, sir. Till
why you telling the muscle
aneurysmal
relaxant?
artery. Till the aneurysm is completely secured, till the surgery is complete, till then bucking is not bucking. We have to stop. So we will use only till the aneurysm clipping is done, sir. Clipping or coiling.
No, that surgery is going to be another 24 to 48 hours. You want to give a continuous infusion? Muscle relaxant.
To prevent any kind of bucking, we have to give.
No. Why you prevent? Why the patient bucks? Why don't you give a heavy sedation? You are giving a continuous sedation. You're giving propofol fentanyl.
Okay, sir. Okay.
Unless I don't know. My other moderators may agree or not. We don't use a continuous infusion of a muscle relaxant. Only have sedation, propofol fentanyl. If you want to do a suction or anything, at the time bolus of sedation could be given to prevent the bucking or coughing of the patient. I don't think we will continuously muscle relaxant be given for 24 hours or 36 hours till the surgery is over. That is my, I don't know either moderators what they will agree or not. What the literature says.
So let's listen to them, sir.
Maybe in a situation where you feel that, patient is going to cone or something like that and patient is bucking. But in any other situation, I will try not to give a relaxant.
No,
Okay.
backing can be prevented by giving heavy sedation, or just because of your sedation is not properly going, maybe your assessment of the sedation score is not good. Just at the time, just only as a bolus, sometimes you want to a quick time, maybe nursing is not good. When you saw the patient is just to give a just big bolus, small bolus, and I don't think muscle relaxant should not be infused. It should not be given.
Okay.
Yes.
Thank you.
Mohan,
Okay.
Mohan, you want to contribute?
No, sir. Nothing, sir. It is a case-to-case basis, as SARS told, usually we won't give as a infusion.
Yes. Sir, my take on this, sir, we don't have to use muscle relaxant infusion, sir, but we have to give deep sedation, propofol and fentanyl or whatever you use, but preferably good and deep sedation so that the patient is not bucking on the tube. And if at all patient is irritable, then the first option is increasing the sedation than going for muscle relaxant. So, but occasionally you may have to keep it ready if at all you have to, but you don't have to give it as an infusion. But if you are depending on it, not boluses, because you don't. My point when I was suggesting was you don't wait for the patient to wake up and then give a bolus. So definitive dependencies on the sedation, but not on the muscle relaxation, a relaxant.
Yeah.
Right,
Is
sir?
there any
Second
trial
question
or
is-
evidence, Achut?
Sorry.
Is there any evidence, a recent article or something regarding this relaxant?
మీరు సిస్టర్క్యూరియం అండ్ అట్రిక్యూరియం కంపారిజన్ సార్ చెప్తున్నారు ఆర్ యూ సజెస్ట్ సార్ యూ పుట్ ఇట్ అక్రాస్
No, I think I have no literature. What I say, I will say, Mohan Maharaj, no neuromuscular agent in the intensive care unit unless otherwise only the ARDS, except that there is no continuous infusion for a muscle relaxant, even anyway. As a, my knowledge, no
No,
infusion
you are
of
true,
muscle
sir.
relaxant,
You are true,
except
sir.
the tetanus. Olden days, no
You are
tetanus.
true. What I'm telling is, for IDCC students, there should be like anything when we speak. No, we have to say because of this article and because of this study.
Yeah,
That's a better way for
maybe.
them to understand. That's all, nothing else.
Right.
There is no literature, sir.
They can
As
quote
such,
the
there is no
ARDS only.
literature.
Only when the hypoxemia, when there is PF ratio of less than 110, 150, something like that, then only they can go for a muscle relaxant. Otherwise, no indication of the muscle relaxant infusion in ICU.
Right, sir. Okay.
One more question, Tripti,
Yeah.
about the
Yes, sir.
prevention of the secondary hemorrhage. That is our most important worry of our intensive care before the surgeons do. Is your worry is only the secondary rebleed. That is a
Yes.
dangerous thing in a SAH.
Yes, sir. Yes,
How to
sir.
prevent it? What is your protocol to prevent the? You told me there is some guidelines, some
Yes,
blood
sir.
pressure, and how to continue, how to monitor it, and how to
Yes, sir.
prevent the secondary hemorrhage. That is the
Sir,
most important.
Yes, sir. So, medical measures to prevent rebleeding 2023 guidelines say that in a patient with SAH, we have to frequently do blood pressure monitoring with short-acting medications, sir. Those short-acting medications are labetalol, ismolol, nicardipine, and clevidipine. And it is recommended-
Just I'll interrupt and discuss it. What type of blood monitoring? Short intervals you're telling. What do you mean a short interval? What type of BP monitoring? Is it a short interval? What type of monitoring you want it? Is it a continuous? Is it
continuous.
interrupted?
Continuous monitoring.
Yeah,
with
you
IV.
told in your presentation, you told me you want to put an intra-arterial line. Beat to beat, you want to monitor the blood pressure.
Yes, sir.
They don't say why you say short interval. You already kept the intra-arterial line. Beat to beat, you're monitoring the blood
talking
pressure.
about the drugs, sir. I think
Okay.
she's talking
Then-
about the short-acting drugs.
Short intervals, as you told.
Sure. Okay, sir.
No, okay. What is the best line of first line of your anti-hypertensive drug?
So, first line of antihypertensives are the labetalol, ismolol, nicardipine, clevidipine. These are the first.
Esmolol.
Yes, sir. Short and short.
Esmolol is, you compare with the esmolol with the labetalol, which is the first line of drug use.
Labetalol, sir.
What is the esmolol?
Sir, esmolol is ultra short acting beta blocker.
And how will you administer esmolol?
We have to administer the continuous infusion, sir.
The
Esmolol.
heavy. What is the dose?
Esmolol, I haven't.
Did you use any time esmolol except the continuous infusion, except during your when you will give esmolol?
Sir, for even for hyper thyroid crisis.
Yeah, there is a that is only during your intubation response, stressor response, when the patient is first line of drug is failed, when there is a sudden fluctuation of blood pressure, then only you'll give a short doses of the esmolol, not a continuous infusion. Very rarely you use that, is very costly, and also you need a lot of drug is should be available. No, labetalol is the drug of choice. Most of them, all ICUs, I think they are using labetalol. But the patient is not responding to labetalol. What is the second line of drug? You told me NTG is an absolute contraindication. When your discussion I heard, I came to know it is that you don't want to give NTG. What is the drug of choice? If the labetalol, still the patient is the labetalol, BP is 190 by 110. BP is not at all. You are giving a highest dose is going on. Then what is the drug of choice?
Nicardipine, sir.
Nicardipine IV or oral?
Oral, sir. 20
oral, you cannot give a oral for a...
Means RT, sir, RT.
Yeah, RT you cannot give it. The response will be take a long time.
మీరు చెప్పండి సార్.
Any drugs are madam? Did you use any time sodium hydroxide? Sodium hydroxide. We have the intraarterial line. Why do you worry about it?
Yes.
Sodium hydroxide. What is the complication of sodium hydroxide?
It has to be completely given in us another. I haven't used it, sir. But we have to see to it that light is not like prevention of exposure to light. We have to seal the IV setting, and we have to
Methemoglobin and testosterone.
Yes, sir.
And then, sir, methemoglobin you are expecting, right? Answer.
Yeah, cyanocobalamin.
Yeah.
That is a cyanide poisoning.
Yeah.
Yes, sir. I haven't used sodium. I haven't used it.
Okay.
Sir.
Right.
Okay.
Sir, any more questions, sir? And others?
No. Other any.
Varalakshmi, you have any questions?
Sir, good morning. This is Dr. Ramana. If surgeon complains there is intraoperative brain bulge.
Sir, your BP target.
Hello.
Hello, sir. Go ahead, sir.
If surgeon complains there is an intraoperative brain bulge, how do you stepwise approach it?
Sir,
Yeah.
Surgeon complains there is an intraoperative brain bulge.
Right.
Yes,
Okay.
sir.
Sir, we'll take that question, sir. Before that, Varalakshmi, you are asking about BP target, right? Is it Dr. Varalakshmi who asked that question? Yeah. Okay. What is your blood pressure target, Tripti?
The blood pressure target should be less than 160 millimeters of mercury, sir, according to
Okay.
guidelines. Yes, sir.
Yeah.
Achyut, in the chat box, one question is there. You can read it. The Rajesh.
1 minute. Okay. Meanwhile, Varalakshmi, please deal with that question. Dr. Varalakshmi.
So, Dr. Tripti, so is there any lower end? Is there any difference during different times during SAH management that your blood pressure targets will change? Do the targets remain same throughout? Say, for example, a patient has come right away in the ER to a time when patient is undergoing clipping, to a time when patient has already undergone clipping or coiling. Is there a difference in targets during these times, or how do you approach blood pressure? Is there a role for vasopressors? How do you manage blood pressure in all the three different stages? That's what I want to know.
In the first 24 hours, we have to make sure that the blood pressure has to be maintained. There are no specific guidelines as to how much we have to reduce the blood pressure, madam. But AHA or ASA guidelines recommend less than 160. The European Stroke Association guidelines say that we have to treat blood pressure only if the systolic blood pressure is greater than 180. Mean has to be maintained less than 110 millimeters of mercury, madam. During coiling or clipping, I am not sure, madam, about the blood pressure target we have to maintain. I'm only aware that according to ASA guidelines, we
And
have
post
to
coiling, do you have any concern?
post coiling. The concern is the surgery may fail if the blood pressure is not maintained. I'm not sure, ma'am. I'm not sure.
Post coiling, the question
Varalakshmi,
is
mere
post coiling, you want to
Varalakshmi.
see something. That is madam's question.
Varalakshmi, మీరే చెప్పండి ఆన్సర్ చెప్పేసేయండి. హలో డాక్టర్ వరలక్ష్మి.
So actually my thing is that are you concerned about low blood pressure post coiling, right? You are concerned because you want to think of vasospasm and how the body tries to compensate or counteract vasospasm. So a lot of studies have shown that what sort of established therapies in SAH and all have failed to work, right? But you know the triple H therapy and all, but there is one component of the triple H therapy that we still use sometimes. That is of hypertension. Post coiling, we don't want lower pressures. So generally, even if pressures are 120, 80, 130, 80, we still target slightly high pressures of 140 over 80. We use vasopressors such as noradrenaline to that end, right? So that is what I wanted to sort of impress on you. And although there are no established studies to show that they prevent the incidence of delayed cerebral ischemia, but we do use the hypertension as a strategy to minimize or reduce delayed cerebral ischemia. Okay, Dr. Priti?
Yes, ma'am. Thank you, ma'am. So as you said, the vasospasm is worsened by hypovolemia, hypotension, so we have to prevent it. Right, ma'am. Thank you.
Rajesh, there is one question about advanced neuromonitoring. Rajesh, can you please unmute yourself? Tripti, what is your what do you call? If you have every monitoring available, every advanced neuromonitoring available, what would you use?
So one is the chances of vasospasm and delayed cerebral ischemia is one of the most common complications of aneurysmal subarachnoid hemorrhage, and it is one of the most important causes of mortality and poor neurological outcomes as well. So there is a reliable role of transcranial Doppler, sir. The advantages of transcranial Doppler are it is cheap, it is non-invasive, and it can be repeatable in the hands of an expertise. So that's the reason why if all the modalities of investigations are available, then TCD is a good tool to reliably diagnose vasospasm. In arterial vasospasm, an increase in blood flow of about more than 120 centimeters per second in the middle cerebral artery in MC8 correlates with vasospasm. The sensitivity is also very high, which is around 94%. Like I said, the advantages are cheap, non-invasive, and repeatable in good hands, in expert hands. The only limitation is that it will not be able to predict distal vasculature information. And also there is one Lindigard ratio, which shows that the flow velocity in MCA to internal carotid artery, if it is greater than 6, then it is definitely
cranial portion. Yeah. Okay. Rajesh, are you there? Rajesh? I think his question was more about advanced neuromonitoring. Probably, I don't know. If he were there, we'll get back to him. Okay. We'll discuss more about vasospasm. Okay. And
Sir,
there was one
can
question.
we ask some more questions?
Yeah, why not? Please post
Yeah,
them. Or you please
I
post
want
them
to ask now.
regarding vasospasm, Srinivas.
Hello. Yeah.
Yes, Srinivas, go ahead.
Yeah. So on the day one, when the patient was intubated and you are going for a CT and you have seen a CT and there is an SAH, but the CT angio was negative. So what is your approach and what are the DDs?
CT angio is also negative, sir.
SAH is there, but CT angio is negative.
Okay. If the CT angio is negative and there is a high level of suspicion, then we have to do catheter angiogram, sir. Catheter angiogram. By calling a interventional radiologist, we can do catheter angiograms.
How will you approach any other DDs?
Any other DDs, sir? I'm not sure of any other DDs how to approach if digital angiogram is negative.
You give the answer what you're expecting.
Yeah. So the patient, if some patients might be in severe vasospasm on day one, so the and you can't see the aneurysm on the first day. Probably, maybe you have to repeat after 2 to 3 days after your conservative management. Second thing, there can be a venous bleed, so where you won't find any aneurysm.
So the peaks of vasospasm is most likely from 5th day onwards, usually, and less likely to see vasospasm on day one itself.
When it is a massive bleed, there are cases where we have to do a delayed CT angio. So we can.
Right. And sir, Dr. Raman question adigaru that about bulging brain anedi. I think it's more about intracranial pressure monitoring. Sir, we'll just move on to vasospasm management. We'll go ahead with vasospasm management, Dr. Tripti.
So, vasospasm and delayed cerebral ischemia is one of the most common causes of mortality and poor neurological outcomes, sir. So, spasm of large intracranial blood vessels, it leads to reduced blood supply to the brain tissue, and this actually peaks around 7 to 10 days. And by 21 days, it actually resolves by itself. But still, we have to make sure that we have to treat vasospasm, and also it is worsened by hypovolemia, hypotension, and anemia. The pathophysiology of vasospasm is what happens is mediators which are released by the blood and tissues, aneurysmal subarachnoid hemorrhage, it causes mediators are released by the contact of oxyhemoglobin with the albuminal side of the vessel. And this causes the vasospasm. And there is also, because of the spasm, there is failure of distal microcirculation, microthrombosis, and also it depends on the genetic makeup of the person. Generally, some people have low cellular ischemic tolerance, so they develop vasospasm more. The percentage of them developing vasospasm is more. So how do we diagnose
the albuminal side of the vessel? Is there anything like that?
So this is the theory which I read in a textbook, sir.
Okay, I don't know what is albuminal side of the vessel. Anyway, yeah, go ahead. Okay, how do you diagnose that?
So one is clinical diagnosis.
If possible. Yeah, okay.
We have to have a high level of clinical suspicion for vasospasm, especially after 7 days of aneurysmal subarachnoid hemorrhage. Any drop in GCS by 2 or more points, which is lasting for an hour at least after 7 days, and it is not attributable to any surgical complications or metabolic derangements, then we should have a high clinical suspicion for vasospasm. Even if we do angiography, only 50% of the cases are visible on angiography. The diagnosis is generally CTO angiogram, and like I had mentioned, transcranial Doppler. And how do we diagnose cerebral decrease in cerebral hypoperfusion is by directly monitoring the brain tissue oxygenation. I haven't seen, sir, by monitoring brain tissue oxygenation. When it is less than 15 to 20 millimeters of mercury, then it is indicative of cerebral hypoperfusion, and mixed venous oxygen return is like less than 7. And
Okay.
or by cerebral microdialysis. So these are the various clinical and radiological ways to detect vasospasm. Already
Okay.
the role of transcranial Doppler has
Tripti,
Sir.
yeah, this cerebral hypoperfusion and microcatheter monitoring, I had that opportunity to do this when I was in doing neuropathy here. It was a research tool. Actually, it's you put a microcatheter into the brain tissue and you look at the brain tissue oxygen tension. Okay.
Right.
And that gives information about the local, not global. It gives information about the local or regional oxygen status of the brain. Okay.
Right.
And we extrapolate that to the global physiology of the brain. Okay. So this is a research tool, and I haven't seen it being used in India yet. Maybe I don't know about the major neuro institutes, but I haven't seen it being used in India. Okay, and then you have mentioned about the transcranial Doppler, right?
Yes, sir.
And
Yes.
and that was in detail, so we'll skip this part. And how do you manage it?
So one is as soon as the patient comes to the ER and the suspicion of aneurysmal subarachnoid hemorrhage is made, in the ER itself, 60 milligrams of nimodipine is instituted, sir, 4-hourly for about a period of 21 days. The thing about nimodipine is it is more because of its neuroprotective nature that nimodipine is used. Also, studies have shown that prophylactic hypervolemia or hypertension is not very effective, despite the fact that hypovolemia and hypotension can actually precipitate vasospasm. Also, before making a diagnosis,
Prophylactic treatment is not required, is what they
yes,
mentioned,
sir.
apart
Yes.
from oral nimodipine, right?
Only right,
Oh, yeah.
sir.
Yeah.
Yes, only oral nimodipine has been advocated, but prophylactic we need not give we need not treat hypervolemia or hypotension treatment. And at the same time, we have to rule out emerging complications like hydrocephalus, which is also a potential complication of aneurysmal subarachnoid hemorrhage. We have to see that we have to rule out any new bleeding.
So these are all the other possible causes
Other possibilities we have to rule out, sir. But once a vasospasm has actually instituted, then triple H regimen in the form of hypervolemia, hypertension, or hemodilution is done. One is
the most important is hypertension, as discussed by Dr. Varalakshmi. Hypertension is most reliable of the 3 triple H's, right?
Yes,
Okay.
sir.
Yeah,
Yes,
right.
sir.
Then
So hypertension, vasopressors titrated to raise the MAP by 10 to 15% above the patient's baseline is recommended. Only 10 to 15% MAP we have to increase, and fluid bolus can be given. But now it is not favored much, sir, after evidence revealed that only hypertension is beneficial. Like, yes, sir. And hemodilution is not generally advocated until and unless there is polycythemia is present.
yeah.
So
The endovascular balloon angioplasty is done by interventional radiologist. Okay.
Yes.
And also into the culprit lesion, we can give intraarterial injection. Right?
Injection.
These
Yes.
are all the drugs, that is nicardipine, verapamil. I think sapavrin is the most chosen one, right?
Yes, sir. It
Okay.
completely causes the culprit artery to. Yes.
Right. Okay. And yeah, the
Sir,
moderator.
one more point to answer for vasospasm, because it is important in SAH. there's been a lot of off-label usage of IV milrinone for cerebral vasospasm, delayed vasospasm especially. And there's a lot of case series and kind of
give the details of off-label use of milrinone.
Yes, it's been if you ask any on the good neurocenters with cerebral vasospasm, people use IV milrinone for vasospasm. We also use for 2 cases. And our center also, we also used, if you remember, for vasospasm, IV milrinone.
Most of the neuroradiologists they are using nowadays.
Right. Yeah.
Okay. And regarding therapy, I think the message has to be clear. So there is no role of hypervolemia and hemodilution. I don't want to get the wrong information or unclear information to the people. It's only hypertension which is the treatment for vasospasm, not hypervolemia or hemodilution. I think that point needs.
So now the triple H has changed. It is not all the 3 given there. It is only hypertension, and hypertension. That's it.
Okay.
I think I'm very clear now. Or we are all very clear now.
Okay.
Right?
Yeah. One thing, vasospasm treatment and hemodipine.
No. Just one more question. Is it a hypertension or is a hypotension to prevention? Is it a treatment? No. The triple H therapy, though, we are not at all advised triple H therapy. The triple H 3H low, they hold only should not cause euvolemia and should not hypotension. Is it a hypertension any drug will use for making the patient go to hypertension? We don't decrease the blood pressure when the pressure is going up. Don't use hypotensive drugs. Don't give hypertensive drugs also. Don't give it unless during the intraoperative immediate.
We give hypertensive drugs treatment. We do give hypertensive drugs for treating vasospasm.
No. When the patient develops hypertension, when the patient is exactly 160, if the patient is systolic blood pressure is 160, do you want to increase the blood pressure till to 200?
Yes, sir. So if patient, any SAH patient who is getting vasospasm and it's been established either TCD based or angiographically, and patient's baseline BP something like at 160/80, patient has vasospasm, you bump it something like 20% of what exactly is the baseline and see for the neurological improvement. If the that has to be the basic thing which we need to do for an established vasospasm, sir. It's not just only avoiding. We should increase the baseline BP at which patient has vasospasm and to see the response once the aneurysm has been secured.
Yes.
If the patient is hypertensive, don't want to put the patient hypertension. If the patient's blood pressure is good, I don't think we go and increase the blood pressure. The vasospasm itself causes the patient goes to blood pressure high.
Sir, if I may talk, sir.
Varalakshmi. Sir, actually we can increase the blood pressure, and I have seen that intervention. We monitor the ECG and STT changes. As long as there are no ECG and STT changes, we can increase the hypertension to a level where there is neurological improvement. And I have seen that intervention in use.
Okay.
Sir, Varalakshmi, please go ahead.
Sir, exactly, sir. It is the path is known in patients. Either you can target a decrease in GCS or an increase in GCS. But if patients are very poor GCS, then we don't know what BP to target, sir. So in that kind of a case, we generally target at least 160 over.
Yeah. Yes. Okay, we'll proceed. Any other contribution from other moderators and others, please?
Yeah, I just want to know about evidence for this nimodipine, because it's in very age-old trial. If we we talk about evidence for nimodipine.
Evidence for nimodipine. Actually, recent 2023 guidelines from AHA. I can't remember if there is any evidence. 1 minute. Yeah, you have any answer, Tripti?
Sir, actually, measures to prevent rebleeding ఇచ్చారు కానీ nimodipine గురించి ఎక్కడ మీరు చెప్పినట్టు మెన్షన్ చేయలేదు సార్. It's there only here, patient with.
Yeah,
Like-
Raj, what is your input? Please give your input.
The evidence for actually nimodipine comes from it's a very age-old trial which was done in 1980s, like late 80s. It's called British aneurysmal trial. I think that's one of the asked evidence because that is evidence. Part
There is a problem with your voice.
It's one of those landmark trials, Dr. Tripti, so you're supposed to know a little bit about.
Okay, ma'am.
Go ahead, Varlakshmi.
Only thing is, study says you should not give a IV. Nimodipine is contraindicated, it causes hypertension. That's the only oral, except the oral nimodipine should not be given a IV formation. But oral formation, what is the drug of choice is only available only nimodipine clinical giving, unless you go to the angiography and angiogram and doing a balloon angioplasty or the giving a intravascular vasodilating drugs like that. Except that, clinically there is nothing, no other except the only increase the blood pressure and the nimodipine drug of choice. But should not be given IV. IV is contraindicated. But nowadays, what I saw some our interventional radiologists, they are using IV nimodipine also.
IV undi sir ippudu.
But still they're using, I don't know. We are telling, we are not at all restricting them. They are coming and they're putting it. Interventional radiologists. They are telling, maybe in their studies they are telling you they are giving.
Okay.
But not all the cases, only case based.
Right. Okay, sir. Varlakshmi and Rajesh, do you have any input on IV nimodipine?
Sir, IV nimodipine, actually, there's been compared to studies between oral versus IV nimodipine, which says IV is a bit better compared to oral nimodipine. It's not an head-to-head comparison RCTs, but there is some more bend towards using IV nimodipine. Off late, as Kuchal Babu sir said, I also seen it once this intervention radiologist started using it, but I've also seen this bit of evidence is there for using IV nimodipine, which is slightly better than oral nimodipine.
Varlakshmi, do you have any input?
Had reports that are causing hypertension. That's it. Now I don't know why they are starting again. We don't know the literature. Might be having some literature.
Right, sir. So,
but in this chart, they have given oral nimodipine as class 1 recommendation, sir, in 2023 guidelines.
Still, you have to say oral nimodipine as a recommendation. IV only if the examiner asks about something, then only you have to say about IV.
Okay. Okay. Noted.
And Rani madam, are you there? Madam.
Hello.
Madam, your input, please. Madam, your input, please.
Input regarding overall or input regarding vasospasm?
You are at liberty, madam.
Nimodipine.
You are the
Nimodipine. Sir, Kuchal Babu sir, I think Madagar neurosurgeons, we are using nimodipine oral only. We are using oral nimodipine, but when you suspect vasospasm, we try to increase the BP little bit to higher side and continuing nimodipine as well. One side nimodipine oral is going, and other side we try to get the BP little higher. So we do both for vasospasm.
Recently we come across this interventional radiologist starting IV nimodipine. I don't know where the literature support is. We don't know. But Rajesh is telling some supports are there. The cinema somebody is telling.
Right.
I don't know. I didn't see. Maybe you might be knowing other people.
Ravi Krishna and Ganesh, you have any input, please?
But anyhow, for the students, you don't say IV. It is only what somebody Kirana somebody told Sinvasa is telling. You should say only oral. Don't say IV. Exam should not.
It should be okay, acceptable. If it is in practice, it should be acceptable. But ground guidelines,
guidelines. You should show the evidence. You should have when you say. You should say this is the quote. Quote the evidence that. Otherwise, don't say. As if we students.
Dr. David, all the seniors please give your input. Every little input helps here, please.
Sir, there is a question. So,
బాబు ఇంకా క్వశ్చన్స్ వద్దు.
వద్దా ఇంకా క్వశ్చన్స్ లేకపోతే సార్ ఇంకా క్వశ్చన్స్
టైం అయింది బాబు, చాలా టైం అయింది, ఇంకా ముగించాలి, ఇంట్లో చెప్తారు.
సరే ముగించండి.
ఓకే
Achyut?
మేడం.
Overall, I just want to say something to Tripti and coming moderators next sessions. Tripti, I think in exam also you have exactly limited time. So when the question is asked, just answer precise to that question only. If we keep repeating the answers or generalized answers, we'll be wasting our time. So you won't be able to finish all the questions in that scenario. So next like case discussions, we try to fix ourselves to like a maximum 1.5 hours. Should not be more than that. I
We
think
are 20 minutes
Achyut, what do
more.
you-
20
yeah,
minutes
I think
more.
today it's 2 hours crossed now. But the thing is, like, students should, whoever is presenting the case, crisp answers, like, so the,
Right, madam.
so
And
we
Dave
should be
sir,
able
are
to
you still
finish
there?
all the questions.
Yes, madam.
Like a students, we are also starting when Visakhapatnam is starting first class. It may take a few classes. It may take the time factor also will decrease slowly. For the time being, 3-4 classes go like this. Then we'll make a protocol how to who should talk, who should ask the questions, who should be only put the questions in the chat box. We'll frame the guidelines. Meanwhile, it should go like this for 2-3 classes. They will know what are the problems. All the seniors should find out and send the feedback. Depending on that, we'll chart out the how to conduct the classes. That also you can make a frame the guidelines. Rani and all seniors, you can make a guidelines for what to do and make the protocol like that. You can say circulate to all the senior people how to question, they should how to contribute to the class. That is also the most important. They have good inputs maybe there. If you don't ask, they won't say. It is also waste for the students. Their inputs is the most seniors input. For every senior faculty input is the most important. The time is not a factor. At least they should put in their answer need not be by verbal. They can send by a chat also. At least they can see the students in the chat box. If the time is not permitted, please all seniors take it as your prestigious. You have a good answer, even though some people may not be knowing. If you know it, please, you have no time. Your slot is not given for to raise your voice. They may be due to the times constraint. Please put in the chat box your answers and questions. At the same time, that will benefit the students. This is my request for all seniors, all the faculty members, all most dignified people. Please send your questions and answers also. If the time is not permitted, please send the answers.
David sir is there? David sir does unnara? Busy unnara? Okay, sir, my sound.
And the main point is not all examiners are as good as and as cool as Achyut sir. Sir baga support chesi answerlani andincharu. So the exam will not be like this, and you will get many more surprises actually in between. Anta sequential ga velladu. So it's for the practice. Sir has given all this liberty.
Whatever your inputs plus, please put on a time is not permitted. You put in a chat box. At least the students will be benefited.
Yes, true, sir. True, very true.
Okay.
Hello, Achyut. Can I add?
Cheppandi, madam.
And the blood pressure control, Tripti told is esmolol and labetalol, and third one is hydrogen. That also we can use. And ICP management, hyperosmolar therapy, serum osmolarity, your target is 300 to 320 milliosmoles.
Yes.
And she's not concentrated ICP monitoring. And the next one is trace analysis. What is P1, what is P2, what is P3?
Right.
And
Yeah.
what are the techniques of ICP?
Yeah, we have
that
such
is-
ICP monitoring in the whole chart.
Yeah.
That is,
Yes.
yeah, yes. One,
That
yeah.
also she has to read. And the next to last one is she is continuously seeing the PPT. So without, and the first presentation is okay.
And it's present,
But when
we are training her for this. Okay, and
no,
one more thing we have touched was
presentation is
EVD
okay.
Yeah, okay.
Presentation is okay. When you are asking the seniors, that time she's supposed to tell the answers. So that is easy for exam.
And one more thing we haven't touched on, the EVD, external ventricular drain, role of external ventricular drain in intraventricular extension of SAH. That is one thing we haven't.
సార్ నేను సార్ క్వశ్చన్ మీరు నా క్వశ్చన్ అడగలేదు అందుకే నేను
బాబు నీ కోసం వెతుక్కున్నాం మేము. We have advanced neuro monitoring గురించి. I called you and you did not.
నువ్వు ఫస్ట్ ఉంటావు కదా నాన్న.
మీరు చాట్ బాక్స్ లో పెట్టేసి వీఆర్ నాట్ సచ్ అచ్యుత్ is asked so many times Rajesh he never answered.
సార్ వన్ థింగ్ ఒక్కటి లాస్ట్ మ్యామ్ ఇంతకు ముందు హైడ్రాలజిన్ అన్నారు కదా, లైక్ డూ యూ హ్యావ్ ఐవి హైడ్రాలజిన్ అవైలబుల్ ఇన్ వైజాగ్?
అనురాధ మేడం?
No idea.
ఓన్లీ ప్రాబ్లమ్ ఇస్ అంటే ఓన్లీ ఐవి ఏజెంట్ అవైలబుల్ విత్ us is labetalol for all these neuro patients. Maybe that only one of the problem.
కూడా ఐవి అవైలబుల్ కదా నిమోడెపిన్ అంటే against vasospasm కానీ as a hypotensive agent we don't use it, but nimodipine IV is also available. Right. So shall we close?
Yes. In Tripti's support, I'd like to say that she had less than 48 hours to prepare for this. So I think we should congratulate her for the effort. And we'll do better next time.
Yes, madam. Dr. Varalakshmi, yes, I don't think she had much time. Ante మరి 1 week అన్నారు కానీ I think she prepared in 48 hours. నాకు కూడా last night I got this.
better you will declare before 10 days. Declare before 10 days.
Sir. We'll close. Yeah. Thank you. Thanks. I thank Dr. Mohan Maharaj, SCCM branch for Vizag branch for giving me this opportunity. Right? Thank you very much.
Thank you, Tripti.
Sir, I also wholeheartedly thank Mohan sir for giving me this opportunity, sir. Thank you so much. Thanks a lot, Achyut sir, for helping me with the presentation. Thank you so much, sir.
It was
Thank you each and everyone, especially Tripti for within a short span of time she presented. Also Dr. Achyut for accepting as a moderator. And thank you all seniors, Dr. Kuchalabu sir, Varalakshmi, Dr. Mohan Maharaj, and finally all participants who are actively participating this case discussion. We'll come with another case in the next Wednesday.
VICCS.
Okay. Thank you, madam.